And our final presenter is from the host here at this beautiful building in this beautiful SUNY Upstate Medical University. Dr. Kristopher Paolino is the Director of Clinical Research for the Institute here for Global Health and Translational Sciences. I think it's exciting and promising because a year ago we didn't have some of the good news here, but he calls it an ounce of prevention, the latest on vaccines for Lyme. So Dr. Kristopher Paolino, please.
All right, thank you. So before I dive into the actual talk about the vaccines, we're going to talk a little bit about the antibiotics and things that we use to treat Lyme and kind of go through some of those shortcomings and pitfalls, and then we'll dive into the vaccine itself. All right, what am I doing wrong here? There we go. All right, so before I get started, I do have a couple of disclaimers. So I do have a relationship with Pfizer. I'm actively the principal investigator for the adolescent study, which we will talk about a little bit. And then I also have done some work with a small biotech from a consulting gig called Flight Path Biosciences. We will not be talking about that at all today, just the vaccine itself. So just briefly, we're going to just highlight the three main syndromes of thought to be active infection, and then the chronic post-treatment symptoms that we can have as well. There's a lot that's already been discussed about the chronic side of things and the variety of different things that could be causing that. One thing I wanted to point out, and we've seen these slides a million times, erythema migrans rash can look like a lot of different things, and we need to make sure that as providers we're not missing it. I still to this day get called in the hospital for flesh-eating infection because there's a rapidly expanding rash that has no pain, no symptoms other than just being there, and I come in and I tell the patient, no, you have Lyme disease. So I think we need to be very cognitive of what we're dealing with in these patients. These rashes don't have to look like the bullseye. That's the other main thing that I see is patients will come in and say, yeah, I had this rash, and I look at it on their phone and it's a clear-cut erythema migrans rash, but maybe not the clear-cut one you see in the top left corner that you see there. It could be, something a little bit more atypical than what people are used to seeing. Or I get people that they tell me that they have had multiple rashes all over the body and somebody disregarded it as Lyme because, it shouldn't be all over the place like that. So just keep that in mind. And then the other thing too is, and it's been highlighted in other slides, not everybody will get a rash. They may not mount a rash response. It may be hidden somewhere. They may be a person of darker skin. It's just something that you need to kind of keep in mind when you're thinking about Lyme. The other main things that we'll see are neurologic Lyme and cardiac Lyme, which are more early disseminated manifestations. And then the Lyme arthritis, which we just had a great talk about, that is more of a late disseminated and is associated with that kind of longer course of infection. This is a now famous slide of a family member of mine who had an early spring flu-like illness that she acquired while she was in school when she was about 9 years old. Didn't think anything of it, stayed home from school for a few days, got over it, fevers went away. And then that September, months and months later, developed this massive swelling in her left leg while she was playing fall soccer. And she went into her pediatrician, who astutely tested her for Lyme and found that she had every single immunoblot band positive at that point, which kind of goes along with that really strong immune response that we see with Lyme arthritis. So these are from the guidelines. This is something that I've come around to over the past 7-8 years, that these are guidelines, right? This is not scripture. And this is not something that I think people need to follow exactly every single time. Every patient's a little different. I have the different dosing recommendations up here that are used. I think these are a good template. I have had situations where, maybe I have a patient who's got a BMI of 40 and they're significantly overweight. Maybe I'll use cefuroxime at a higher dose just because of the therapeutic window. As far as kind of durations of treatment for these different symptomatologies, These again are guidelines based on some of the literature out there. I will say personally, I don't treat anybody with erythema migrans at this point in my career for anything less than 3 weeks. I think it's something where I see more of my patients coming in to see me in consultation with persistent long-term symptoms after getting a 10-day course or a 14-day course of doxy or amoxicillin, depending on their situation. So that's one aspect. The other one, it says doxycycline for meningitis or radiculopathy. I rarely will use that unless absolutely necessary. I've seen too many treatment failures and recurrent symptoms with meningitis recurrence or recurrence of severe headaches and things like that when people are sent out on just doxy after only a couple of days of IV ceftriaxone. I think maybe the doxy would be a great option if you were in Europe. I think the strains of Lyme over there may be a little bit more susceptible to doxy, and a lot of the Lyme neurologic infections are associated with doxy as part of their treatment protocols. I don't prefer it. I usually give people a 3 to 4 week course of ceftriaxone. And then there's a couple of these others down here. Again, I usually will go a full 3 weeks with Lyme carditis cases. I find that if you cut it a little shorter than that and you do 14 days, you might have a little bit of a risk of a relapse. Again, these are some of my own anecdotal experiences. So that's kind of everything from an antibiotic perspective. What is also in the guidelines is they do talk about the use of DMARDs for Lyme arthritis. So one thing that I have kind of adopted, and I think Dr. Steer has kind of highlighted in terms of Lyme arthritis, is people come in, you start treating them with doxycycline. It's almost everybody gets doxy up front. And I think it's partly because that's what we're taught in medical school. Everybody knows that you don't die without doxy, first of all. And the other is that if you hear the word tick, you immediately think doxy. I think that's something that we teach the medical students. It's not a bad idea because it does help treat some of the co-infections that we deal with. And in our area here, we're seeing this big surge of anaplasmosis cases. But it does seem to have a real risk of treatment failure. And I think it does have something to do with the bacteriostatic nature of the drug. So what I will do when I see somebody coming in with persistent knee swelling or persistent joint swelling with kind of clear-cut history of Lyme arthritis is I'll go to one of the beta-lactams and try to use something that's more bactericidal. I usually start with an oral option, amoxicillin, 500 milligrams 3 times a day, cefuroxime, 500 twice a day. They both I've had good experience with. If that doesn't work, I will then go to the more invasive intravenous ceftriaxone and try that. I don't generally treat for more than 4 weeks. Occasionally, I will go to 6 weeks. And on a very rare occasion, although with not much benefit, I've done 8 weeks of therapy. When I complete my treatment with IV antibiotics, I will then go to some of those DMARDs, right? So I, in the past 3 years, have given out more doses of hydroxychloroquine than I think I have in my entire career as a physician. So, and it does help with a lot of these patients with this kind of post-infectious Lyme arthritis presentation. Once I get into the realm of like sulfasalazine, methotrexate, I get a little anxious and I send them to some of our rheumatology colleagues. And then I have had one patient who actually went to a very enthusiastic orthopedic surgeon who went and did a synovectomy and basically cleared out the entire joint. Patient's knee pain and swelling went away within a week or so of the surgical swelling going down. So everything, everybody is a little bit different in terms of their presentation. The chronic Lyme symptoms is the main thing that we worry about. We don't want them to get to that point. And I think one of the things that I feel was probably hammered home to me as a medical resident, medical student, and even fellow was that you treat the person, they're treated, they're done, then next patient. And I don't think that's the approach that we want to take. I think the way that I generally treat patients is I have very close follow-up, anywhere between a month to 3 months after I see them that initial time, because I want to make sure that they're not going down this path of chronic Lyme. And is there something I need to do else? Do I need to treat them again with a different antibiotic class? Do I need to try some of these other options that some of the other providers have discussed? So these are all things I see. Every single one of my patients with chronic Lyme has at least one of these things, and they can be very difficult to treat, even with the best efforts. So we want to prevent them from getting there, right? So the way that we're going to do that is all the things that we talked about with Brian's lectures and other things you've heard about. You want to do tick checks. You want to shower after coming inside. You want to use the topical repellents. You want to use permethrin on your clothes. I think a vaccine will also be an additional tool. It is not going to be the be-all, end-all of prevention, but I think it will add another layer of protection for people. And the first thing that people always ask me is, well, my dog has a vaccine. Can't I just take that one? And I'm like, please don't do that. Don't take a canine vaccine. But it is important to understand that, there have been vaccines out there, and I'll talk a little bit about the history of human vaccines as well. So my understanding, I'm not a veterinarian, obviously, but there are 4 different types of Borrelia canine vaccines that are out there. They seem to be safe and efficacious from what I can tell based on some of the veterinary websites. Most of these all induce antibodies to that outer surface protein A. There are a few of them that seem like they also have OSP-C involved as well, which potentially adds this additional layer of protection. But the thing that makes these vaccines interesting is their mechanism of action. So we had an OSP-A vaccine that was approved back in the late 90s. And it stuck around for, I think, 4-ish years. I think it was approved in 98, and it was eventually discontinued about 4 years later. It was found to be fairly immunogenic and efficacious, although the long-term data in terms of how long the antibody response lasted was a question. But the reason it went away is because of the controversy. So there was some thought that these patients that were getting the vaccines were developing a Lyme arthritis type syndrome. So people were basically saying, kind of like what you hear with the flu vaccine, oh, the flu vaccine gave me the flu, right? There was a similar kind of presentation where people were getting sick. They were having this arthritic kind of presentation, and they had to look into it. So this was the Lyme-Brix vaccine. The initial vaccine study that was published in the New England Journal of Medicine was a fairly large study, almost 11,000 patients in multiple centers, randomized, double-blinded, kind of the perfect scenario in terms of a treatment trial or a vaccine trial. And they basically said that after the first year of vaccinations, the 2 injections, efficacy was about 43%. But then when you got that booster vaccine the following year, you did get a bump up to about 76%. Now, they had something in there that talked about like asymptomatic Lyme, I guess based on seropositivity versus not. And after 2 years, it had 100%. I'm not really sure what that means clinically. But at the end of the day, it seemed like it was a good step in the right direction. There were some side effects. They were generally thought to be mild to moderate in nature, and they lasted about, on median, 3 days or so. So there was no evidence of any kind of long-term arthritic symptoms or anything like that, although that did kind of make it into the news. All right, so this is what they showed in terms of that study. A lot of people who had the vaccine itself had some soreness at the injection site, which is not uncommon with the vaccine. There were some patients that will have some muscle aches or myalgias that lasted a couple days after the vaccine. Interestingly, I don't think there was really a significant difference, at least in those first month, of arthralgias or joint pain, which became more of a problem later on. Even after that 30-day cutoff, you can see there's really not a whole lot of a difference, at least in the confines of the study itself. As far as immunogenicity and an antibody response, you can see that when they check the antibodies at that, you can't see the little arrow here, but if you see the first dot up on the top there, you had a nice bump in your initial immune response and an antibody response that then dropped down to about at the 12-month mark from that 1,000 range to about 100. And then when they gave that booster, it went back up. And at least by the 20-week mark or 20-month mark, there was still pretty good persistence of antibodies. So again, we had a vaccine. It seemed like it had a good antibody response to the bacteria, and it seemed like we were doing okay. The problem was that within about a year of the vaccine being released, there were a lot of reports of people developing these Lyme arthritis type symptoms. There were a lot of other side effects, but really the musculoskeletal stuff was what most people were arguing was the most debilitating. There was a big negative media push in terms of highlighting these patients, and I think it's good that they were getting the word out there. But at the same time, it really colored this vaccine in a really poor light. There was eventually a lawsuit that was brought to light. And because of that lawsuit, there was a reevaluation of a lot of the data. The FDA did this kind of unbiased review where they took a look at all the different adverse events in the phase 3 study and basically tried to determine whether or not there was any validity to these symptoms that people were having and if it was potentially related to the vaccine. There were definitely more side effects associated with the vaccine in the study itself, but really nothing, like I already highlighted, that were anything unusual from the standpoint of an actual immunization. And one of the things that people highlighted as a downside is they were only followed for 12 months in the vaccine study. And that's pretty typical for a vaccine study. Most vaccines, they're going to be followed for at least 6 months. We try to do it as long out as possible, but unfortunately, there's only so many funds available. And when you get past that 12-month mark, you get a drop off in patient participation, and it makes it harder. And that's part of the reason why we have other ways to monitor this stuff. And this is the same reason why we identify the myocarditis in the COVID vaccine patient population. So when you're doing these vaccine studies and you have an 11,000 person study, it seems like a really large study, but when you have a rare side effect to that vaccine, you're not going to pick it up. All right. So even these huge studies like COVID, we enrolled, I think, 40,000 plus people in the COVID Pfizer vaccine. You're not going to pick up those things of myocarditis. You're not going to pick up things like, Lyme arthritis type symptoms. So one of the things that they did is they looked at the vaccine adverse event reporting system, or VAERS, and they looked at how many million doses had been given of this vaccine. And then they looked at the number of these arthritis reports that were out there. So there were reports of arthritis after the vaccine, but it was nothing above and beyond what we would normally see in the normal population, the background data. So it did not seem like there was any association. And then one of the other things that they looked at is if there was a spike in those cases of arthritis after subsequent doses, which they did not find. So unfortunately, we are now without a licensed vaccine for Lyme disease. You can see it came out right around 1998. Within a year and a half or so, they had the class action suit that was filed in 2001. FDA advisory panel kind of reviewed everything. And despite the fact that everybody said, we don't think we need to pull this from the market, it still seems like it's safe. It doesn't seem like it's causing arthritis. There was such a poor reaction to the vaccine and just a dramatic decrease in interest that they pulled the vaccine in 2002. So that fast forwards us to our current leading vaccine. So Valneva is a small, I believe, Austrian company that is partnered with Pfizer to basically revamp this idea of using an outer surface protein A vaccine. And they term it VLA15. That's currently what it's called. I'm sure it'll get a nifty name when it actually gets licensed. Phase 1 and phase 2 studies have been completed. I'll go through a little bit of the data that's recently been reported in the literature. Really no significant safety concerns have been identified, right? That's part of the reason why it's moved on to the phase 3 study, which started last August and in 2022. And then they also have various sub-studies, one of which we're part of here at Upstate, looking at more of a pediatric population. So I'm in charge of the adolescent group of 12-year-olds to 17-year-olds here at Upstate to really kind of get more robust pediatric data. And so far, I have not seen anything that was above and beyond what I would normally expect from a vaccine. This is from the phase 1 study. This was actually just reported, I think, in the past 3 months or so. So this was a smaller study. Phase 1s are generally smaller. This is primarily looking at safety. They were only looking at 18 to 40-year-olds, and they were looking at 3 different dose concentrations kind of throughout. And the doses, I believe, are the 12 micrograms, the 48, and then the 90. The current doses, I believe that they're using is 180. So we've actually had more data since then. But really across the board, there wasn't a huge difference between the different doses. And these were also adjuvanted, and there wasn't a huge difference between those that were adjuvanted with alum versus not. You can see a lot of patients would have tenderness and pain, as would be expected after a vaccine. Really very little erythema at the injection site, very little swelling, itching, or any induration. So very similar to what I would expect to see with most typical vaccines. And these were all very short-lived in nature. More systemic symptoms. So the ones that they identified in the phase 1 study. So lot of headache, very little fever that we've seen. And then a couple other things like, some flu-like malaise type symptoms, fatigue, a little bit of muscle aches, and very little joint aches that were identified. And again, very short-lived in nature. As far as our adolescent cases, we've had some cases that have reported headaches, really no fever. Fatigue has been one, although it's always a question of whether or not the 15-year-old that's staying up until 2 a.m. playing video games is fatigued because of that or the vaccine. But it's been something that I would expect to see in most vaccine studies. And then as far as antibody responses, these are just a highlight of the geometric mean titers. And then these are the different serotypes that they were looking at. So you can kind of see across the board of the different doses. They're all fairly similar. I think the higher doses may have a slightly higher geometric mean titer, but these are basically just talking about the overall antibody response that people are having. They did not talk a lot about any kind of long-term follow-up or anything. As far as other vaccines that are out there, the only other one that's listed on clinicaltrials.gov, which is where you would go for a trial that is being used in humans, is by Moderna, where everybody must know who Moderna is at this point in the COVID pandemic. They have an mRNA vaccine, actually looking at 2 different vaccine candidates and looking at a 7-valent approach. And they, I believe, have already started recruiting, but I don't know how far along they are at this point. I do believe that Rochester, New York is one of the sites, though. As far as mRNA vaccinations, there's this thought that it can induce this kind of tick resistance, if you're using it in the setting of like a salivary protein kind of a vaccine. So this is not the Moderna vaccine. This is something different. But one of the things I know that Dr. Tangamani has been interested in is creating a universal tick vaccine, something that would allow you to either not have the tick stay on and stay attached for a prolonged period of time so you wouldn't have that transmission, or something where you might have a response to that kind of salivary cement that could then allow you to either have some itching or pain at the site of the tick bite, make you alerted to it more readily, and then take it off faster. And there was a study that was done here in mice that looked at this particular mRNA vaccine that shows that within about 18 hours or so, the mice were already starting to get an inflammatory response in the vaccine in vaccinated mice versus the control mice. And you can see by the 72-hour mark, which is longer than you would want to have a tick on for, just a really intense immune response. And the hope is that something like this would allow you as a hiker or somebody who enjoys the outdoor to not only do your tick checks, not only do your permethrin on your clothes, not only do your repellents and everything else, but also have something like this in your system that would allow you to identify that tick as rapidly as possible, and then hopefully avoid any kind of transmission. And this is just kind of going into like how it works in these guinea pigs. Basically, unvaccinated guinea pigs, they get infected. They don't really have much of an immune response, whereas the salivary protein binding antibodies from the vaccinated individuals, they develop that rapid erythema and response to the tick bite itself. And then hopefully we'll be able to remove it within 24 hours or less. There is also the idea of using monoclonal antibodies. So there's like it or not, there is definitely an anti-vaccine component to our country and really the world. Whether or not it's warranted or not is up for debate. But some people just will refuse to get vaccinated, and it's unfortunate. But there are some people that are out there that are looking at monoclonal antibodies as a possibility for prevention. This study back in 2018 looked at using this antibody infusion as a way to prevent a Lyme infection from an infected tick, and basically showed in this mouse model that you had decent protection. One of the candidates had 92% protection at day 42. It's a short-lived study. It was only followed up for that 6-week period before euthanasia. But this is something that has been discussed, and there is a group in Massachusetts that's looking to take this a step further and take it into human trials. I have not seen that they've actually started the human studies yet, but it's something that they're looking at doing. In terms of like a larger, not safety study, but like an efficacy study. So that's pretty much it from the vaccine standpoint. I wanted to kind of keep it short and sweet since we have a lot that we don't know yet. And we're not sure how long it's going to take the vaccine that's currently in development to make it to market. My guess is we'll have some preliminary data by next year. And then maybe by 2025, if this is fast-tracked as I'm expecting it to be by the FDA, we may have a licensed vaccine based on the data that they have. But that all depends on if it is shown to be safe in the larger population and shown to have some, at least some good immunogenicity data as well as some efficacy data. So with that, I'm going to leave the floor open for any questions.
Please, Doctor.
Thank you. That was really great to hear the latest. So, I read in the news or heard a few months ago, I'm sure you know where I'm going with this, some challenges with third-party vendors as far as enrolling and non-compliance. Without going into too much detail, do you know about how long that's going to set the study back?
That's a good question. Yeah. So initially I was going to be part of that study, and they decided they wanted to shrink the study down. And I think what they wanted to do is focus on multi-center approaches that would maximize that. So they looked at large hospital systems. Like if you want to be part of that study, Guthrie apparently is like a multi-center site just south of here. You can enroll in Cortland. And the problem with that is they relied on large clinical research organizations to run these studies, and those are businesses. And my understanding, without getting too much into the weeds, because I don't know the details, is that there were some informed consent issues and maybe some inclusion-exclusion criteria issues where they may have disregarded the protocol at these sites run by the CRO and enrolled people who probably shouldn't have been enrolled, or didn't consent them appropriately for enrollment. So they had to throw out a lot of that data. I don't know how long it's going to set it back. I know that they are still enrolling. And when I was initially approached to be in that study as a PI, they were hoping to have the entire study enrolled by last December. So my guess is it's probably going to take an extra year. I'm still hoping that by the end of 2025, we might have some data, but that's had nothing to do with the vaccine. It was just the groups that were running the study. So
Who else? Question for Dr. Paolino.
Going to my usual suspects, but
Other than that bump in the road that you just explained, do you see any other bumps in the road for this promising vaccine?
I mean, the biggest thing is you want to show that it's effective. And they initially have the study listed as 18,000 people, and then they decided to shrink it down to 6,000. I think they then bumped it back up to 18,000. So I'm hoping that's enough to get the efficacy response. They're doing this study in essentially the Northeast and like I think the Wisconsin, Michigan area as well. So they're looking at doing it in high risk populations, Mid-Atlantic, New England, all that. It's just a matter of making sure we get enough of the cases, right? So, and it's hard because you got people on a tick study or a Lyme study. You want to make sure that you're telling them, to do the right thing, But at the same time, if they're not being exposed, then they're not gonna know for sure. So like if I tell people in my study, I'm like, hey, don't go out and roll around in the grass just because you got this vaccine, right? So it's just a matter of making sure you get the number of cases. So.
Yeah. You're right here, yes.
So Chris, is the previous Lyme's infection exclusion criteria?
That's a
For the
good question. So if you've had Lyme, I believe in the past 3 months, it's either 3 or 6, you are excluded from the study, until that time frame has gone past. What they did explicitly exclude are the later manifestations. So if you've had Lyme carditis, any kind of neurologic Lyme, or especially Lyme arthritis, again, because of that immune response that people have talked about, you don't want to color the study inaccurately. So there is some theoretical thought that because of that really robust immune response to Lyme arthritis, that you might have some immunity to it, and that would obviously sway the study in the wrong direction and cause some problems. Yeah. Go ahead.
You also get possibly antibody responses in some Lyme arthritis.
Yeah.
Hi. I was wondering, you mentioned that the new vaccine is going to be different from the previous one. How are they revamping it?
So I always have to look this up, but they basically, when they did that FDA review, there was this, let me see if I can pop back to it. There was a specific HLA DR that was highlighted as maybe, yes, that may be associated with the response in the Lyme arthritis. They basically changed the way that this vaccine was made in a way that excluded that risk. So that's the change that's been made, and so far we haven't seen anybody with any kind of significant arthritic issues.
Chris, I don't have a question, but I want to know if you want to. I think either you or I can tell the group how the vaccine actually works.
Oh,
it's not
yeah.
a traditional vaccine as we think vaccines.
As I was going through the slides, I realized I think I left that out. So, so the cool thing about this vaccine, and this is something that, like as somebody who's worked on vaccines in the military and, has seen a variety of different things. I've worked on malaria, hantavirus, anthrax, dengue, Zika, Ebola. I've done all those vaccines. All those vaccines do the same thing. You mount an immune response, and your antibodies or your T cell response, depending on the vaccine, is what helps protect you, right? So you have that in your body and you're protected, right? So if you get infected with Ebola, your antibodies are there to fend it off. With these vaccines, the OspA antibody affects the tick itself. It's inside the tick. And, this is something where, it attaches to the spirochetes in the gut of the tick when it takes in that blood meal, and it inhibits you from getting that transmission to occur. And that's what I think makes this vaccine very kind of wild, because you're not even getting the protection in your own body. It's almost like a transmission blocking vaccine, like you would see with some of the malaria approaches. So that's what makes it kind of interesting and more a little bit a bit different than what we normally would see. So.
When it comes and when it works, do you still have to knock the tick off, or is that only that other vaccine? In other words, will this vaccine work?
Right? Yeah, it's not going to knock the tick off.
No,
you still got to pull the tick off, because what this vaccine, the Pfizer vaccine, is not going to do is it's not going to protect you from babesia. It's not going to protect you from anaplasma or any other co-infection. The two big ones that we have in our region are babesia and anaplasmosis. I've seen a ton of anaplasma to the point now where I'm making the diagnosis over the phone. It will not protect you from that. So you do need to take off the tick. You do need to monitor for symptoms afterwards, regardless of whether or not you get this vaccine or not.
Yes.
So would that type of vaccine require people to have a continued immune response, or would you have to be monitoring to make sure people continue to have detectable levels of antibody?
So that's a good question. So the initial studies didn't really go on beyond the 12-month mark, and the vaccine wasn't out for very long. So I don't think we have a good idea as to how long this will last. And it goes back to Rob's lecture, where there's either going to be a scenario where you're going to have to get boosted every year or two, or they're going to have to come up with, Pfizer Valneva 2.0, where they have something that helps boost that immune response a little bit better. My guess is it's probably going to be something where we're going to get boosted until we get a better product.
Anybody else?
It's late in the day.
Thank you, Chris.
Yep.